everyone. I am Dr. Apoorva Hajirnis, practicing endocrinologist at Bhaktivedanta Hospital and Research Institute, Mira Road, and Harmony Center for Diabetes in Thane. Today we'll be discussing a case of poorly controlled diabetes with hypoglycemia risk. So our patient is a 50-year-old male, type 2 diabetic since last 2 years. He came with frequent hypoglycemic events in the past 2 months. He is currently on metformin 1000 mg twice a day and sulfonylurea glimepiride 2 mg twice a day. His lab results are HbA1c is 8.2, LDL cholesterol is 90 mg per deciliter, HDL is 36, triglycerides are 126, AST is 33. His creatinine is 1.4 mg per dl. So eGFR for his age, when we calculate, it comes to about 59 ml per minute per 1.73 meter square. So he is in stage 3A of CKD. His physical examination shows blood pressure of 120/70, heart rate of 78, and BMI of 31. So he is obese. So in this particular patient, optimizing glycemic control with cardio-renal protection are the primary treatment considerations. HbA1c goal for most non-pregnant adults is less than 7%. However, considering he has already developed complications of diabetes, namely nephropathy, we need to control his HbA1c to less than 6.5, provided we can do such a thing without causing significant hypoglycemia or any other adverse effects. So, in the 21st century, type 2 diabetes has reached epidemic proportions globally. Indians have a tendency for earlier onset of type 2 diabetes, leading to an accelerated risk of developing complications, making it more essential to address diabetes right from the day one or very early in the course of disease. So, strict glycemic control is critically important in people with type 2 diabetes. Sulfonylureas play a pivotal role in glycemic control. We all know that. However, as a direct extension of their mechanism of action, which is to secrete insulin from pancreatic beta cells, the risk of hypoglycemia is obviously increased. And this risk may be further increased in patients with renal impairment, which is a common comorbidity associated with type 2 diabetes, like in our patient. Hypoglycemia is a major concern for users of sulfonylureas. Magnitude and severity of hypoglycemia-induced hypoglycemia, sulfonylurea-induced hypoglycemia ranges widely across studies. There is strong rationale for combining DPP-4 inhibitors and SGLT2 inhibitors because they are CV protective class, because these two drugs exert different and complementary glucose lowering effect. We know that DPP-4 inhibitors act to incretin effect and SGLT2 inhibitors act at the level of proximal tubules, secreting extra glucose through urine. So this is a complementary action. Furthermore, the increase of glucagon levels sometimes induced by SGLT2 inhibitors may be blunted by this combination, because we know that DPP-4 inhibitors not just enhances insulin secretion, which is food dependent, it also reduces glucagon secretion from the alpha cells. So clinical evidence shows that SGLT2 inhibitor and DPP-4 combination is an effective option for management of type 2 diabetes, providing HbA1c reductions of 1.1 to 1.5% and weight reductions of approximately 2 kg when added to metformin, which is its primary place in therapy. So this is very important, that the added benefit of weight loss is going to help us treating the patient on every possible aspect, including hypertension, dyslipidemia, risk of cardiovascular disease, so on and so forth. So, the American Diabetes Association recommends initial combination therapy should be considered in patients presenting with HbA1c levels of 1.5 to 2% above target range. Considering absolute effectiveness of most oral medications rarely exceed 1%. So, this is a very good combination. It's a unique combination which is good for early intensive treatment of type 2 diabetes, because it can achieve HbA1c reduction which is 1.5% with added benefit of good tolerability, low risk of hypoglycemia, possible weight loss, and minimum treatment burden. Clinical experience with DPP-4 inhibitor and SGLT2 inhibitor combination shows that they can be used with good safety profile and low risk of adverse events, namely hypoglycemia and weight gain, even when added to metformin, which is a particularly important finding for clinicians. So, a reduction in the incidence of genital infections associated with SGLT2 inhibitors has been reported when DPP-4 inhibitor is added, perhaps because of a better glucose control through other possible mechanisms. So, with this, I would like to end my talk and thank you everyone for patient listening. Thank you.